Good afternoon, everyone. Thank you all for joining us today for this special webinar. My name is Ashley, and I'm an MS3 at Zucker School of Medicine. We are honored to have our distinguished guest speaker with us today, Dr. John Boockvar. He's the Vice Chair of the Department of Neurosurgery at Lenox Hospital. He's also a Professor of Neurosurgery at the Zucker School of Medicine, as well as the Professor at the Feinstein Institute for Medical Research, where he directs the Laboratory for Brain Tumor Biology and Therapy. Today, we have the privilege of hearing from him as he shares his expertise on Y90 radioembolization to treat glioblastoma. We will be reserving some time at the end for a Q&A session, so please have your questions ready and you can add them to the chat box below. And if you guys like, you can also keep your cameras on. Without further ado, please join me in welcoming Dr. Boockvar.
Thank you, Ashley. Can you hear me okay?
Yes, we can hear you.
Okay, good. All right, I'm going to share my screen. A couple of disclaimers. First of all, I received no compensation from Boston Scientific, and they did want to provide me the talking points. That's how sort of companies work. This is kind of proprietary, so they wanted me to use their presentation. So I have no, line item veto power over what they gave me to present, but I can talk about it freely. But I think it's important that you know that I don't get any compensation from anything that I do. And I think from a student perspective, and actually my patients always like to know that also. So one of the first things I say to my patients is, I just want you to know I have no financial interest in this study. I have an academic interest, but and of course any spelling mistakes are not mine. So that's most important. This is a really interesting study and actually dovetails a lot of what we do with intra-arterial drug delivery. And frankly, Ashley, I had a bunch of slides before this because this is a read-only slide. I wasn't able to add it to their presentation, but perhaps at a later date or sometime in the future, we can talk about other intra-arterial drug delivery trials that dovetail this. But this is a pretty cool trial for glioblastoma. And we'll talk a little bit today about this trial. We'll talk a little bit about intra-arterial drug delivery, and we'll talk about glioblastoma in general, and then I'll take some questions. So a TheraSphere obviously is a radioactive bead, and obviously talking to a group that's interested in endovascular and vascular delivery, using the arteries to supply a tumor is obviously a more efficient way to get a drug into any tumor than it is giving something intravenously or orally. Hold on. So let's talk a little bit about what TheraSphere is. These are small, insoluble glass microspheres, about 20 to 30 micrometers, containing yttrium-90. And yttrium-90 is a radioactive isotope. You can see that they're about the size of a human hair follicle. And we use intra-arterial Y90 in the treatment of hepatocellular carcinoma. Now, intrahepatic artery delivery of these Y90 TheraSpheres is effective in the treatment of hepatocellular carcinoma. And again, yttrium-90 is basically a radiation microsphere that's going to deliver radiation through your microcatheter and penetrate within the tumor and give off this local radiotherapeutic dose. So, do you guys see in the lower right, Ashley, you see the intra-arterial beads that are in the artery going into the tumor down on the bottom right? This is our intra-arterial drug delivery technique where we're giving these microspheres through the artery. So the idea here is you have selective catheterization of arteries that feed the tumor bed, and they deliver these small microspheres that then lodge in the small microvasculature and release yttrium-90 into that microenvironment. This targeted localized delivery of radiation then causes DNA strand breaks and all the things that radiation is known to do to tumor and dividing cells. So this is sort of where some of my trials come into play. We are looking at many intra-arterial drug delivery approaches, Of course, one of the reasons that I'm interested in intraarterial drug delivery is we have to get past the blood-brain barrier. The blood-brain barrier, as you all know, is you can see a little diagram of it in the top left up there. And we have used a whole host of techniques to try to bypass the blood-brain barrier, whether it's liposomes, receptor-based, sort of what we call Trojan horses. Um, we bypass using catheters that go directly into the brain. And intraarterial mannitol and other agents are a way to cause basically gap junctions to pull apart, and we can get large volume of drugs out of the lumen of the vessel into the microenvironment, as you see in the picture depicted. So if there are students in the, listening, if you really want a cool project, someone should be studying the blood-brain barrier. It's one of those, the holy grail of what we do. And everyone's studying glioblastoma or aneurysms, but actually bypassing the blood-brain barrier is really something that is of utmost importance. Here you can see in the right of the screen, a patient with a brain tumor in my left is the patient's right. So in B as a boy, you see this enhancing lesion in the patient's right thalamus. So you can see the selective catheterization of this patient in one of the posterior lateral medial choroidal vessels. The intraarterial drug delivery technique is a very effective way to do selective catheterization of the brain. So you're giving drug here, in this case, yttrium 90, in the distribution of just that tumor. So the rest of the brain, you can see on the angiogram, is spared whatever treatment you're getting. So that's why intraarterial drug delivery is better than intravenous. What happens when you give a drug intravenously? You put it in your vein, it goes back to the heart. The heart has basically a cardiac output of about 5 liters per minute. 20% of that goes to the brain per minute, so that's a liter per minute. And the rest goes to the rest of the body. So whatever you're giving in the arm is going to every other part of your body, and only 20% per minute is going to the brain. Intraarterial drug delivery, 100% of your payload is going right into your tumor. So like the liver, intrahepatically, we're looking at intracerebral vascularly to deliver high dose of chemotherapies. We have a trial using intraarterial bevacizumab, which is Avastin, intraarterial cetuximab, which is EGFR monoclonal antibody. So we've trialed these both in kids and adults with brain tumors. So again, we're going to talk about TheraSpheres. This is a radiation-based treatment. As most of you know, radiation really is effective in dividing cells. It causes DNA strand breaks. Basically, what we're asking of these hair-sized beads is to actually, these glass microspheres are administered. They're actually going to have, they're going to be directed toward this microvasculature. They're going to embed in the microcapillaries and exert a local radioeffective dose. Of course, what we all worry about is, can they cause strokes? Actually, some of what we want to see is this, what we call microembolic effect. We want microembolic, we don't want macroembolic, right? We want micro, where we can see diminished blood flow to a tumor, and that can cause relative apoptosis, but we don't want to cause stroke. And that's why for this particular trial, we're exceedingly cautious. But the rationale of this trial is to get selective delivery, allowing radiation to exert its effect on the tumor directly. Now, getting this through in a patient with hepatic mets is quite different than a patient with a brain tumor. Why? Because the side effects or the off-target effects or the risk is going to be much higher if a patient has a stroke in the brain, as opposed to a small little microembolic event in the liver, which is obviously compatible and has redundancy. So in the United States, TheraSphere is indicated now only for the use of selective internal radiation therapy for 1 to 8 centimeters in patients with unresectable hepatocellular carcinoma, or HCC. Patient, of course, has to have some liver function and a good performance status, meaning the patient has to be able to tolerate the procedure. So It's important to note that in the United States, this procedure is FDA approved only for hepatocellular carcinoma. So moving it into something like glioblastoma can actually be risky for a company like Boston Scientific. And in fact, I'm pretty impressed that they're willing to do it. Most companies say, oh, I have a label, we're making money, I don't want to risk it by moving into something so small and narrow like glioblastoma. So I credit Boston Scientific in taking some risk here. And of course, it's helpful for our patients. I'm going to talk a little bit about some preclinical work that they did, which I think is just really fantastic. And I don't know, my dog is sitting next to me, so I love dogs, but unfortunately, dogs get gliomas. And spontaneous gliomas in dogs actually is a great opportunity for us because it's lethal to dogs. And a company like Boston Scientific can, of course, work with some big veterinary institutions. When I was at Penn, our veterinary school was a very big school, and we were able to use spontaneous gliomas in dogs to do some great trials. Not everybody has the opportunity to do that, but I credit again Boston Scientific for doing this. So here's the Y90 canine study. So again, they used 3 dogs here, spontaneous glioma patients, and they're patients because they have spontaneous gliomas. And they were given 60 gray to both normal brains and then actually 5 glioma patients here who are dogs. And all these dogs presented with seizure and or a neurological deficit. Just to let you know, these dogs die very quickly with no treatment. So the median survival is only 2 months for a spontaneous glioma in a canine. And these patients, these dogs, were then given yttrium-90. 5 dogs were given yttrium-90, and there were 3 controls. And because of the vascular anatomy in the canine, it was more of a hemispheric, less selective yttrium-90. So there was higher risk because of the less selection of the intraarterial drug delivery. But I want to just bring your attention, I don't know if you can see my arrows, but there's a little sagittal image in the bottom left here. You can see the spontaneous glioma here in the canine brain. And then in the third panel is the axial T2, and there's some contrast enhancement. And here's that cute little dog, Billy, who did great from the yttrium-90. Again, the median survival without treatment is only 2 months. Here's Billy alive, greater than 2 years. So they did some great studies, and this basically canine study was what got them basically moving into humans. And you can see what they first did was do a post Y90 PET scan. So yttrium-90, which is a radioisotope, they moved the patient into a PET scan. And you can see what's fascinating, and I think even they were surprised, that with hemispheric intraarterial drug delivery, the Y90 basically localized in the tumor and the surrounding edema. And I'm not quite sure I understand exactly. Well, first of all, there's a relative amount of blood flow that's preferential to a brain tumor that's hypervascular compared to normal tissue. But fortunately, yttrium-90 seemed to localize to that tumor. So you can see in the picture above are the MRIs without the yttrium-90 PET scan. And then after the yttrium-90, you can see the yttrium-90 localizing around the tumor, meaning that this has a propensity to go where there's high blood flow and lodge there and provide some selectivity. You can see how cool the angiogram is in these canine models. So again, the absorbed delivery was hoping to get up to 60 gray. This is more of a hemispheric delivery based on the angiogram anatomy of a canine. The good news was that the majority of the tumor got the radiation yttrium-90 and not normal brain. And so the absorbed dose approached the normal human dose that we give, which is 60 gray. And again, what you want to see is some selectivity of the yttrium-90 preferentially going to areas of tumor and not of normal brain. And how cool is this? I mean, all of the animals had an initial reduction in the tumor volume. So you can see above, there's a baseline A and D actually, and then at 1 month and 6 months. So yttrium-90 had a very good local effect on reduction in tumor volume. You can see here all of the animals. Well, these are 4 animals: patient 1, 2, 3, and 4. So they had an initial reduction. Some stayed below their baseline. Some approached baseline after 6 months, and some started to grow. And I'm not sure why. But again, the median here without treatment is only 2 months. So you can see with a single dose, this achieves some durable responses in some of the patients, which is frankly all that we asked for. And again, they looked at clinical outcomes, much like we do in our humans. Patients obviously presented with seizures. These dogs presented with seizures. And so, following this endovascular radiosurgery, if you will, all of their seizures or neurological deficits that they incurred from the treatment resolved within about a month. So that also is favorable. Obviously, we don't want neurological deficits, but the survival from treatment in days was impressive. Of course, you have one dog who lived more than 2 years, one dog who lived, 2 dogs that lived a year. So these are good results in canine models from the first dose of yttrium-90. Okay. So that gave them a rationale to go to the FDA and approach humans, right? So glioblastoma is a universally fatal disease with a median overall survival of about 12 to 15 months. And so the idea of the working hypothesis is, can they take this canine data and apply it to humans, where we look at selective internal radiotherapy to the T1 enhancing disease, which you see in A as an apple. And then we usually have about a centimeter or 2 of surrounding T2 hyperintensity. And can we give, as you see in this angiogram, selective intraarterial yttrium-90 to newly diagnosed patients once to and see if it's safe and effective. So again, what's the why? The why is our intraarterial delivery, much like we're doing with the hepatic artery, to do a cerebrovascular artery, super selective microcatheter delivery, hopefully getting a localized dose to the tumor while minimizing normal tissue exposure. The isotope is Y90. Y90 is actually quite good because it has a short half-life. It's kind of bad. It only penetrates approximately 2.5 millimeters, but that means it's very localized. It's got a quick on-off, and it should have a low embolic potential, meaning it shouldn't cause a stroke. And so that low embolic amount needed to achieve the high dose should reduce the risk of stroke. And of course, our GBMs are high flow and hypervascular. And so blood flow to this high-grade glioma, much like we saw in the canine model, we expect to have a higher blood flow relative to normal brain. And once the beads embed in that area, that's when they exert their effect. So again, the canine study informed us that this would be hopefully what we'd see. So that's when they took it into glioblastoma and reached out to me to be one of 5 sites in the country to roll out this trial. So just a little bit of the background of primary brain and central nervous system tumors. The majority of central nervous system tumors, which include the brain, the spine, and the peripheral nerves, brain and spine being central, are most of the brain tumors. Most of the CNS tumors are in the brain. The majority of them are gliomas. The majority of brain tumors are either glioblastomas or metastatic tumors, which are not really listed here. Obviously, pituitary tumors and meningiomas are benign. This is sort of so anytime you're talking about a biotech company or what's your appreciable market, this is not a big appreciable market. So even Boston Scientific, which is this massive company and has a ton of opportunities elsewhere for them to approach a market that only has about approximately 5,000 patients per year, again, is just great for us because most companies shy away from this small, appreciable market. But nonetheless, they came to the idea that they would be able to help 5,000 patients per year, which is tiny. We call that an orphan disease, but we're grateful that they've taken a dive into it. So just to let you know what the NCCN treatments are for low-grade gliomas, obviously we always want to enroll patients in clinical trials. At Lenox Hill, obviously Amanda said a little bit about what our health system is. We are the largest health system in New York State in Northwell Health. We have the first allopathic MD medical school, new medical school in New York State in 40 years at the Hofstra Northwell School of Medicine. There are 21 hospitals. I only operate at Lenox Hill Hospital, but our labs are on Long Island. We basically have two laboratories, Cold Spring Harbor Laboratories, home of 8 Nobel laureates, and the Feinstein Institutes for Medical Research. But we run a huge amount of clinical trials. We run 33 human clinical trials out of Lenox Hill Hospital, and some of them are for low grade, some of them intermediate grade, some of them for high grade brain tumors. Low-grade brain tumors obviously do far better than glioblastoma. And again, our role is to enroll patients in clinical trials. Just to let you know, all patients who enroll in clinical trials outperform patients who don't enroll in clinical trials, even if the clinical trial patient gets a placebo. Why? Because the placebo effect is real. The Hawthorne effect is real. Hawthorne effect is observed patients do better. And so we always want patients enrolled in clinical trials. In this trial for glioblastoma, obviously we would want those patients usually get surgery, radiotherapy, adjuvant temozolomide with or without what's called tumor treating fields. So all of that is allowed in this trial with Yttrium-90. This is just a slide showing kind of at the molecular level and the gross anatomy. Many of you, if you're in med school or any PA or nursing school, you'll know the cerebrovascular anatomy of the brain. And that's great because as endovascular specialists, you'll be microcatheterizing all of these big vessels, the circle of Willis. We know that obviously the middle cerebral arteries, the basilar, the vertebral arteries, all of these arteries are catheterized thousands of times in the United States per day for stroke and aneurysms, aneurysmal rupture, stroke retrievals, for a host of other things, vasospasm, et cetera. So, but this is kind of the microvascular setup of the basic blood-brain barrier, which we talk about astrocytes, pericytes, and all of the growth factors involved with tumors. Sorry. So what you will be doing is vascularizing and putting microcatheters in this distribution to deliver these spheres. So as you can imagine, here is just a coronal cut with a view of the internal carotid artery as it bifurcates into the anterior cerebral artery and the middle cerebral artery. This is showing aneurysms along that course. And of course, the hard thing with this, which I don't do, but my physicist does with our basically nuclear medicine colleagues, is they have to do a CT perfusion study, which basically maps each GBM patient. And they then will determine if those patients are capable of getting Yttrium-90 based on the CT perfusion. And of course, we don't want to see any evidence of infarcts. And most of our patients have some distribution relative to the M2 segment of the middle cerebral artery. But interestingly, after many, many discussions, in this first trial, which I'll mention shortly, we only are treating dominant hemisphere, non-dominant hemisphere glioblastoma, either in the temporal lobe or the frontal lobe, and that's just to make sure that we don't have significant side effects. All right. What I'll do is just sort of walk through the clinical trial, and then I'm going to open up to some questions. All right, so any clinical trial basically, they make it look easy, but setting up a clinical trial, getting FDA approval, getting IRB approval, and obviously getting consent forms, legal documents, it takes a while. It could take 1 to 2 years just to get a trial up and running. This is called a frontier trial. It's a prospective interventional single arm, meaning that we're following patients prospectively. It's obviously interventional. We're doing a treatment. It's a single arm, meaning that all the patients will get intraarterial Y90, multi-center, Lenox Hill, Neurosurgery, Northwestern, Mayo Jacksonville, and I'm not exactly sure what other sites are up and running, to assess the safety and technical feasibility of TheraSphere GBM in patients with recurrent GBM. Actually, that slide is they're calling it TheraSphere GBM. It really is for first recurrent GBM, meaning that multiply recurrent GBM is really not kind of the patient that we're looking for. The primary objective is to evaluate the safety of this microsphere in patients with recurrent glioblastoma, and the secondary objective is to evaluate the technical success and efficacy. Up to 12 patients at up to 5 sites will be enrolled in the study. That's it. So we're only looking for 12 patients. We've in this study have done 2 so far. The population is recurrence, and the follow-up is going to be obviously as an inpatient, and then 7, 14, 21 days later, and then monthly for 6 months, which is basically standard. This is going to be a descriptive report, meaning that there's no statistical hypothesis. We're just looking for adverse events, safety, and secondary survival endpoints. So as you can see on the right, the primary and secondary endpoint, really toxicity. That's all we care about. The FDA just wants to make sure we're not going to hurt somebody. And, frankly, we're doing a lot of trials that are risky. I've run vaccine trials. I've run bacteria trials where we put small pieces of bacteria in patients. We're putting autologous flaps in our patients with GBM. And we got to take some risk because it's a dreadful disease. And so even though there's some risk here, it's worth it if it works. Again, we're just looking for grade 3 CNS toxicity, meaning strokes. We want to make sure there's no stroke, there's no radiation necrosis. Obviously, these other grade 4 severe neutropenias would be unlikely because it's a local treatment. And obviously, secondary endpoints include, how's the patient doing? What's the progression-free survival? What's the overall survival? And again, this is just another summary of the primary endpoint. But this trial, 12 patients, is a safety trial. This trial with 12 patients is a safety trial. And of course, we hope to expand this trial should the results end up being effective. So how do we screen our patients? We have a big clinical trials office, and obviously we get patients from all over the globe. And we're strict in who we include because we want to make sure that they are, one, going to comply, and one, they're not going to get, obviously injured from the treatment. So patients have to be of the appropriate age. They have to be surviving with their disease greater than 6 months. They have to have a confirmed diagnosis of GBM. So that's an IDH wild type glioblastoma. And they have to have progressed from the standard of care, meaning that they've had to have gotten 6 weeks of radiation, chemotherapy, and shown progression. There are certain things that they're allowed to have had and certain things that they're not allowed to have. Every trial has a washout period from the treatment before. So in our trial, they cannot have gotten temozolomide within 4 weeks or lomustine within 6 weeks. So there has to be a washout of the previous treatment before we go on and do this treatment. And most importantly, on angiographic mapping with CT perfusion, we have to decide that the neurovascular anatomy is going to allow for safe microcatheter placement in a single location. We talk about that internal carotid artery, MCA, and we have to be able to infuse a TheraSphere to treat all of that contrast enhancing component by our neurointerventional team. So we have to make sure we sort of cherry pick the best patients here. We like a small treatment volume in this first 12 patients so that we don't have a big exposure and again, negative outcomes. How do we exclude patients? Obviously, we were saying sicker patients do worser, right? So we don't want our very sickest patients to have a risky clinical trial. They will not do well. So we exclude patients who have bilateral disease in both parts of the brain, both hemispheres. If they have had multiple radiosurgery, again, this is a radiation-based treatment, so that can cause more radiation necrosis. So we exclude patients based on the number of times they've had radiation and the number of times they've had surgery. If they've had wound-related problems, radiation can exacerbate that. And again, on the bottom here, the angiographic mapping, if patients have significant vascular disease or they have a lot of intra cerebral stenosis, for example, or significant AV shunting or tortuosity is going to make the angiogram difficult, those are not great patients. So we take all of this seriously. We hope to show that this is safe over the course of 12 patients. And this is also a treatment that can be done in any hospital that has endovascular treatment. So I would expect all of those here on the call, if you're interested in endovascular treatments, this is sort of where the puck is going. And that's our trial with intraarterial yttrium 90. I think that's it. That's all they're allowing me to show. So Ashley, I'm sorry. Ashley, I will open it up to the group if they have any questions.
Thank you so much for this great presentation. We're just going to be shifting to the Q&A session now, so please feel free to unmute yourself to ask a question, or you can type your message in the chat below.
I have a question. Do you know if there are any modifications that they made to the Y90 spheres that they use for HCC for the brain cancer? Like, is it the exact same product, or did they mess with the specifications?
My understanding is the exact same product.
One question I did have was that usually when performing Y90 radioembolization to treat HCC, during that initial mapping angiogram, sometimes any arteries that are passing from the liver circulation to any nearby organs, they're typically embolized with coils to prevent any radiation damage to those areas. Given that the anatomy of the liver and the brain are vastly different, would that be done in this case?
No. I mean, obviously, that's, first of all, an excellent question. We have to, we use balloons, Ashley, instead of coils because balloons are temporary. One of the things, and we spent a lot of time in committee trying to figure out what was the safest thing to do. And that's why we're only using one vessel. So basically, they've asked us, you have to pick a patient that the entire tumor is just supplied by one vessel. So we can slide a catheter, let's say, to a supratemporal middle cerebral artery branch. And basically, we don't have to worry about the yttrium 90 getting out into, let's say, an inferior frontal branch or something like that. So we won't need those coil techniques. And then hopefully, based on the canine data, the yttrium will preferentially go to the blush of the tumor and stick there. It's always interesting, though, having to consent, and I consent every day. And patients always ask me, oh, how are the patients doing in this trial? And I say, oh, you're going to be, patient number 3 in the world. And you'd think they would, run away. And the way you tell them is you say, look, like you said, Ashley, this is a treatment that has been successful in other parts of the body. We don't know how it's going to work in glioblastoma. However, our catheter-based techniques are getting better and safer and more skilled every single year. And based on this canine data of spontaneous glioblastoma in canines, it's the rationale is very good. And then the patient's like, okay, sign me up. So but I've run many trials where a patient looks at me and says, John, how are the rest of your patients doing? And I look at them and I say, you know what, you're gonna be the very first patient we do this on. And they're like, whoa. But that's part of the fun of it. And obviously we lay in front of our train for our patients to make sure they don't get hurt.
It looks like we have one other question in the chat. How do you add your surgical expertise to the research and development process?
It's funny. I spent the day in the lab. That's why I'm casually dressed and home with my canine. But it's a really important part of my day, my week. I operate twice a week. I spend 2 days in clinic, consenting patients and seeing pre and post operative patients. And then Wednesday is my academic day, and I'm in the lab at Cold Spring Harbor. And today we had a talk. We actually do multiple cancers, and our postdoc today presented his data on head and neck squamous cell carcinoma. And it really doesn't matter what cancer you're studying at the basic science. I mean, it does and it doesn't. But I looked at him at the end, and he was so deep in the pathway, basically sort of phosphorylated STAT3 downstream of STAT3 activation and in head and neck cancer. I'm talking at like the chromatin level, so BRD4 and chromatin remodeling and phosphatases that he was looking at. And I said to him, so I'm a surgeon. Tell me what drug, where are you gonna, what's the clinical trial you're gonna write? And he was sort of dumbfounded by my question. And I think that banter going back and forth, and I asked a student last week, how are you gonna get it through the blood-brain barrier? And she's like, I'm not sure. I said, all right, this is all good. Maybe we have to do intraarterial drug delivery. Maybe we have to talk about convection, ultrasound. Just it's a very important part of using your surgical expertise. Bringing that basic science into the operating room is equally as important as bringing your sort of realistic techniques to the bench.
What is the timeline for completion of this part of the clinical trial?
It's funny. I think they thought we would finish much sooner than we did, than we're doing. I think the inclusion and exclusion criteria is very, very strict. And I would expect by end of 24, we're done. That's my hope, with sites doing about 2 cases each. One of the things that is not on the slide is they actually prevent patients who have had intraarterial drug delivery for another clinical trial from getting intraarterial Y90. And we have many intraarterial trials at Lenox for newly diagnosed patients, and those patients are already excluded for yttrium 90. So we've been begging them to allow us to give yttrium 90, and they haven't acquiesced. So we'll see. We should close in 24.
One other question we have in the chat. One of the side effects of Y90 in the liver is post-embolic syndrome, including right upper quadrant pain, fever, nausea, etc. I know that it is still early in the trial. Do you have any expected findings for post-embolization syndrome in the brain?
Well, our canines all had neurological deficits, so the answer is yes. I think whether it's a seizure, mild neurological deficit, brain swelling, I expect our patients are going to need to be put on steroids. I think we'll see something. The question is, and I think what we'll learn over the course of time is how big a volume we can give, right? So the bigger the volume, the liver is big relative to these glioblastomas. So I don't expect our volumes to be that big where we should expect significant neurological deficits, but I expect there to be some swelling from this.
Is that a transient effect or
Yeah,
will it?
most of the canines were done by 33 days. They had returned to their baseline.
Another question we have is, could you expand more on what it means to treat GBMs on the non-dominant side versus the dominant side? What would it take to treat GBMs on the dominant side with this technique?
So look, the dominant hemisphere, so 99% of right-handed people have a dominant left brain, and 50% or more of left-handed, unless they're familial left-handed, will have majority of their function on the left brain. So we know that the risk is going to be higher, right? So if I take a left dominant hemisphere temporal GBM and put Y90 and they develop a postoperative neurological deficit, that patient's going to be aphasic. And so that's a really tough existence. So we don't want to cause deficits in patients with dominant hemisphere glioblastoma yet. And you may say, well, if it's transient, then it may be worth it. And we do that all the time, but we're starting with non-dominant patients so that any neurological deficits will not be sort of life altering. They may get weakness, they may get swelling, but they're not going to be aphasic or, basically have severe memory loss, productive or receptive aphasias. Does that answer that question?
Another question is, since this is the first clinical trial assessing safety, how is the amount of activity to be injected decided?
So that's a very good question and above my pay grade. That's up to our nuclear medicine people based on the CT perfusion and how much blood volume is. Anytime I do radiation, we implant cesium-131 seeds into GBM also. It's up to my physicist to decide how many seeds. And frankly, I have no idea. I give them a volume and they say, okay, John, you can do 5 seeds of cesium-131. So I honestly don't know how they come up with the amount based on volume, but it's a volume-based amount. And I would expect that if I say, okay, here's a 3-centimeter lesion, they're going to say, okay, John, you can give however micro, spheres of yttrium-90. But that would be a question I expect, if you're interested in nuclear medicine or physics, that would be a question you can answer in the future. I hate physics.
One last question I have out of curiosity. Other than nuclear medicine, what is the other medical team involved in the Y90 treatment for GBM? Are neurointerventional radiologists also at Northwell also involved in this?
100%. So Jonathan Weinstein and Yafel Cerule are two interventionalists. They're the pitchers. In fact, I'm like the manager at this point. I just sort of walk out onto the field and give them the ball and then they throw. So again, they're the ones that are delivering the Y90. They're just my patients. I screen the patient. Interestingly, I consent the patient, but they do the procedure. And then our physicists and our nuclear medicine team are the ones that are doing the preoperative assessment. So it's really a great team. And obviously, we have a lot of experience in intraarterial drug delivery. And if any of you are in the neighborhood or want to see any of these procedures that don't include yttrium-90, and of course, if they do include yttrium-90, Ashley, I'm happy to we do have students who are onboarded and watch some of our interventional drug delivery treatments in our angio suites. That's a possibility.
I might take you up on that offer. One final question in the chat is, can you tell me about the treatment of glioblastoma with gold nanoparticles and radiation?
I'm not sure which treatment they're referring to.
Would whoever asked that question like to specify?
While we're waiting, I do have another question, if that's okay. Could you see this being feasibly effective for like multifocal GBM in the future?
You know, unfortunately, I think there's risk to that, right? Because you're gonna have to do multiple vessels. The risk of doing multiple areas in the brain increase, especially if you have side effects. So I think unfortunately this is going to be not a great trial for patients with multifocal JBM.
Okay, thank you.
Okay, I think with that, we'll close off our presentation today out of respect of your time. But thank you once again to Dr. Boockvar for your valuable insights on the future of GBM treatment. And thank you to everyone for their active participation in today's session with the West Coast Vascular and Interventional Society. I hope everyone has a great evening.